Okay, thank you for having me. It's a pleasure to be here. I don't very often get 100 people in a room and get the opportunity to brag about the wonderful services we provide at Providence Care, so I really appreciate this opportunity. I wish our interprofessional teams could be here so that I could brag a little bit in front of them, but I really appreciate this opportunity. Just to share a little bit of background, we at Providence Care, and I'm focusing on some services at St. Mary's specifically, but we do focus on programming associated with specialized geriatrics in terms of medical support and rehabilitative support. So obviously that's to promote health, prevent decline, and of course to restore health, and that's a big part of our focus. Often these people come to us who have experienced some acute medical incident or a decline in health or some sort of deconditioning. So what we often focus on is the restoration of health, and that is something we're exceptionally good at. So I'm very pleased to share with you today. So I'll touch on a few of our services. As well, embedded in the services that I'm speaking of, we've had a couple of quality improvements over the past couple of years to improve access to these resources and to improve patient outcomes. So I'll share those as well. So first of all, we have, just as an overview, specialized geriatrics outpatient clinics. So we have a geriatric medicine clinic, a memory clinic, and a continence clinic. And by clinic and outpatient services, I'm referring to you come from community for an appointment and have a follow-up session with a geriatrician and perhaps a specialized RN in geriatric services. We also have Seniors Day Rehabilitation Services, and again, this is an outpatient service, but it's more a sequential opportunity for therapy over a number of weeks period, and it is an outpatient services provided by an interprofessional team. And finally, what we alluded to was the inpatient unit, which is our Assess and Restore unit, which is comprised of specialized geriatrics patients as well as restorative rehabilitative care. So I'll get into what those mean in a little more detail. We also have the Center for Studying in Aging and Health, and this is a center of excellence, really a resource for our community stakeholders, for other healthcare professionals to provide a capacity and information to build capacity and promote successful aging, prevent or delay the expression of frailty and its harmful consequences. There's a lot of resources on the website. I've included it here for your interest. Lots of resources, education and training resources, etc. So have a look at that when you get the opportunity. And I would be remiss if I didn't throw in one demographic slide here. This is just representative of our LHIN, and I presume most of you know the geographic span of our LHIN, from about Trenton to Perth Smiths Falls, east to west, and north to Maynooth-Bancroft area, so quite a large geography. And if you take a look at this slide, the gray line, the solid gray line, represents the provincial expected growth of our population over the next 10 years. So it's expected that the population will grow generally, all ages, at about 10% provincially. In our LHIN, our growth rate is much lower. We're expected, that's that black line, the solid black line, we're only expected to grow at about a 5% rate. But what's really remarkable here is in our LHIN alone, that dotted line is an exponential growth rate of our seniors population. So we're growing by 35% in that area. So the reason I include that, it really speaks to the importance and the need of our service and the specialized regional support that we provide. And I have to certainly express that we are in full alignment with all the legislation as well as guidelines and strategies that are in place both regionally and provincially. The Excellent Care for All Act is sort of a no-brainer. It's a must-do. We provide the best quality care, best safety that we can provide, and incorporating patient and family engagement in the review and evaluation of that safe and quality care. There's also an older adult strategy being implemented by our LHIN, and we're in direct alignment with the mandate of that strategy. We are a senior-friendly hospital and align with the strategies of that, which really include optimizing patient health while they are in our building to promote a safe transition home. As well, we're aligned with the Assess and Restore guidelines and the Rehabilitative Care Alliance. And what these are best practices both associated with senior frail elderly as well as just rehabilitation practices that support the best practice around assessment and interventions for our patients. And I just had to show a picture of what's coming soon. In about a year, we'll have the wonderful opportunity to move into a brand new hospital, merging both the mental health site and the St. Mary's site. And all I can say about the excitement of this is, with the exceptional work that we already provide, I can only imagine what it's going to be in a state-of-the-art building with all the wonderful equipment and resources. So exciting, busy times, but exciting times to come. So the geriatric medical clinic, just as an overview, this is appropriate for patients that have medical issues or cognitive concerns, and then you can be referred by a family physician. It's led by a geriatrician or a care of the elderly physician, and it's meant for assessment and follow-up, probably 2 to 3 appointments. And as Megan alluded to, that polypharmacy issue with frail seniors is often an issue, and we have a geriatrician that often does a medication review and tries to reconcile the needs, particularly those long-standing medications, and getting some of those off the list of required medications. And that's a key area of focus of these clinics, as well as addressing cognitive concerns. And of course, referrals and recommendations back to community and to the primary health teams come from this. We also have a Seniors Day rehabilitation program, and this program is designed to support those who are failing to cope and live independently at home. It's an opportunity for that restoration that we're looking at. So here's the target population, that frail older adult over 65 with complex chronic diseases, functional decline, perhaps recent falls, medication concerns, or perhaps frequent emergency department visits or acute admissions, mood or memory or cognitive concerns or changes, or recent unexplained changes in health status. As well, we have an SLP on staff, so they're always looking at changes in swallowing status and nutritional needs. So this service is provided, as I say, by an interprofessional team. There's a geriatrician, there's also care of the elderly physicians. We have registered nurses who specialize in gerontology, physiotherapists, occupational therapists. So physiotherapists looking at mobility, falls prevention, occupational therapists looking at activities of daily living, bathing, eating, dressing, cooking, that sort of thing. Speech language pathologists, as I mentioned, speech, language, and swallowing issues, and social workers looking at the psychosocial needs of our patients. So this is where some of the redesign work came in about 1.5 years or so ago. We had a fairly long wait list for this service. It's obviously not something readily accessible in the region. It's a specialized service, and people were waiting a significant time for it. So what we did was redesign to basically open up access to the service by delineating those who needed complex medical issues addressed with a geriatrician as well as the interprofessional team, or those that simply needed some support around falls or swallowing, that sort of thing. So the RN supported stream with the full interprofessional team. And by doing so, we really increased access to the service and reduced the wait times. We also increased our allied health support. We added physiotherapy and speech language pathology resources, and we improved coordination of services. And I'll just show you a little bit of data. So the first slide, the first column shows in 2013-14 when this work had began. This is our new patient volumes, our annual volumes, and we had 211 patients in that year. In the subsequent year, following the redesign and the work that we did, we had 322 patients. And you'll see the next column that's a different color reflects 3/4 of a year, so still that growth, and then the projection for 15-16 at 408. So really doubling our numbers, which means we're giving more people the opportunity for this rehab to live at home independently with improved function and quality of life, of course. So concurrent with that is the visit volumes went up. And by visits, I mean if a patient comes in and they come for 2 to 3 times a week over 2 to 8 weeks, those visit numbers each count for each member of the interprofessional team that they see. So we started in 13-14 with about 1,900, and in our projected 15-16 year, we're at about 3,100. So really good numbers to show that we're doing the right thing for our patients. So these are some of the outcomes. We streamlined our referral process, we increased access to the service, increased annual volumes, reduced our wait times. We increased the intensity of the service. So not only did we ramp up how many allied health professionals are in the building for these patients, but they have a more intensive encounter when they come to our service, which of course has a huge impact on improved patient outcomes. We also improved our relationships with external stakeholders, made them more aware of our services and linked in that regard. And we also improved our linkages to our own internal inpatient unit so that when people transition and discharge from hospital, they are transitioned to this outpatient service. So there's some continuity of care, some feeling of safety, and that the service isn't discontinuing. So that was an important piece for this. And finally, we have our inpatient unit, which I'm very proud of. We have a remarkable team on this unit, very similar to the team members that I described in Seniors Day Rehab, geriatrician, care of the elderly physician, all of the allied health professionals, all specializing in specialized geriatric services. And they do remarkable work. And within this combination, it's a 32-bed unit comprised of both specialized geriatrics and restorative rehabilitative care. That was an initiative that we worked on about a year and a half, 2 years ago, and I'll just share some results of that. So this particular service, it's one half of that 32-bed unit, relates to what we call a slow-paced rehab. So what that looks like is, you're probably all very familiar with physical medicine and rehab at St. Mary's of the Lake. It's an exceptional service, but not all people are eligible for that service because they may not be able to tolerate the level of intensity of the service or be able to achieve their outcomes in the time required. So this is a new service that we introduced back in 2013, and as more beds became available, we ramped up to be fully at capacity in 14-15. So it's obviously filling a gap in the region that wasn't otherwise there, giving people who wouldn't have had the opportunity for rehab that opportunity. These happen to be high-risk people to be going to long-term care simply because they have more severe impairments, a slower recovery trajectory. So it's, a very good news story if we can transition these patients home. So our biggest probably highlight and success story here is that 65% of those RRC patients have been discharged home. So that's quite significant. And you'll see the length of stay down at the bottom. We're averaging at about 54 days for length of stay, and the provincial mandate allows for up to 90 days there. So we're achieving those outcomes in a very timely way, which again means improved access for the next patient to come through the door. And here are just some stats relating to the unit as a whole. So Gibson 3, Seniors Restorative Care and Specialized Geriatrics as a whole, our average age on admission is 80 years. 95% of our referrals come from KGH and community. So you'll see here for 14-15 we had 247 admissions and 210 of those came from KGH. And this speaks to our close partnership with our acute stakeholder in that we're continuing that trajectory of recovery for those patients. They are our patients jointly. And then those that we bring from the community, what we're doing there is mitigating the risk for an emergency department visit or an acute care stay. So they're coming directly into a restorative setting rather than going through potentially a not required traumatic event in acute settings. So there are some that are sort of saved from that event by coming straight through. And these are our discharge numbers in the same fiscal year. We had 221 discharges, 143 were discharged home, and only 11 discharged to long-term care. So that's a very strong success story. Obviously those two don't make up 100% because there are a number of other discharge destinations, excuse me, such as supported assistive living, unidentified or undesignated destinations, other acute centers. But another success story within this is those who transition from our G3 slower paced unit to our fast-paced units. So we had patients making gains sufficiently to go to that level of care. So they're included, not in those discharge numbers, but included in the process of their recovery. So with all process improvements, we have a very stringent process around making sure we're doing things right, and that's that PDSA cycle. So we plan something, we carry it out, we study it, we look at, does this work? Should we tweak it? Is there anything we need to do to improve upon it? And then we make those improvements and carry on. So that's part of our process. So lots of great successes that happened over the past couple of years, and we continue to have good patient outcomes. And I'd like to share a couple of quotes here. The kindness in which therapists helped me gain confidence so that I could do things for myself. The pool exercises were helpful to strengthen my legs, making my mobility better. The nurse and doctor were very understanding of my situation. We are hugely impressed by the quality of care and the level of concern that we experienced at Seniors Day Rehab. Each team member determined how to best apply their talents to my problems. Wonderful communication, both of the staff and with outside individuals and organizations to address our needs. So this is Murray, and I have the distinct opportunity of sharing Murray's story, and I'm sorry that he can't be here today. Murray wanted to be here, and he asked if I wouldn't mind reading his story. So I'm going to do that. I can't do it justice. Murray has the most wonderful sense of humor, and I like to think I do, but I'm not sure that I can articulate it. But quite a remarkable story and a remarkable man. So I'll just share his story now. It is a great privilege to be asked to recount my experience with St. Mary's of the Lake. I certainly wish I could have made this presentation in person. However, due to a previous medical appointment, I was unable to attend. First, to put my picture in perspective, I am a 78-year-old male who has had Parkinson's disease for several years. In mid-October 2015, I suffered a seizure which left me in the Ottawa Civic Hospital for over 2 months in a coma. I was then transferred to Kingston General for another 3 weeks where I tried to stand. I was then transferred to St. Mary's of the Lake for rehabilitation, and it was then that my rehabilitation commenced. I could not walk independently, sign my name, eat with a fork, cut my meat with a fork, or drink a coffee or pick up a pill off a tray. The staff were great and demonstrated great patience and knowledge of my problems. Some of the exercises seemed rather immature for me, but I quickly found that to listen and repeat the exercises, as trivial as I thought some were, was quickly regaining my mobility. I was soon walking the hall with a walker 5 times around at a time. That's a fairly big unit. And doing that twice a day. Then came the challenge of going downstairs for rehab. The stairs proved a challenge, but not as much as the walking and the bending to pick up articles, with and without the assistance of a walker. Within a few weeks, I was advised that my stay in the hospital would come to an end. I certainly felt I would be okay, but not strong, and wondered if I would ever get back to a normal life. That was when Jennifer King, an occupational therapy assistant, took me in a wheelchair downstairs to what I thought was going to be the morgue and suggested that I roll in the Seniors Day Rehabilitation Program. The best move I made in my life of recovery. There I was assigned to Jeanette Dick, physiotherapist, a no-nonsense person who introduced me to a series of exercises, one at a time. Today I consider the exercises simple, but at the time I had a great deal of difficulty doing so because of my balance. I found my walking improved immensely, and as I took longer strides and swinging my arms and walking faster, my balance improved. With the help of Jen Burkus, who is an occupational therapist, I was now able to print my name and sign my name. I cannot still write long sentences in a readable manner if I'm at all excited, but I can print if I take my time. The difficulty I still have is the cell phone and the computer, as I strike a letter several times requiring correction. I found the nursing staff, doctors, and team also very patient and helpful at St. Mary's. In summary, I have been back twice for assessment, and I am amazed at the progress, not only month to month, but by the day. It is amazing how far I have progressed from a near vegetable state to where I am today, living independently. Most important, one must exercise every day. Here's his lesson to you. If I don't do this first thing in the morning, by noon I shake like a leaf. The 3 things that made my recovery possible were prayer, the doctors and nurses, and the St. Mary's of the Lake rehabilitation team. Thank you. Marie Lawrence Moore. Are there any questions? Thank you for your time. Actually, one more thank you. On behalf of our patients, family, and staff, we thank you because we know your generosity. Without your generosity, our success of our programs would not be possible. So thank you for your time.